All right, welcome everyone to the APSA Practice Committee 21st Century Cures Act, Information Blocking and Implications for Pediatric Surgery.
Hi, my name is Tony Escobar. I am a pediatric surgeon and trauma medical director at Mary Bridge Children's Hospital in Tacoma, Washington.
And I'm Stephanie Chow. I'm a pediatric surgeon and trauma medical director at Stanford Children's Health in California.
Well, the 21st Century Cures Act. This becomes live on April 5th, 2021. And as the practice committee, we wanted to give you a primer on what to expect as all our EMRs are switched to on in terms of sharing our notes, labs, radiology reports with our patients and patients' families in real time. So where did this all start? CMS passed the interoperability and patient access rule, which created a new condition hospitals had to meet to participate in Medicare and outlined interoperability requirements. Payers and health plans must make patient-facing application programming interfaces, or APIs, available by July 2021. And hospitals were required to share real-time electronic event notification with the patient's PCP and other providers by May 2021. CMS and the Office of the National Coordinator for Health Information Technology, or the ONC, began requiring Medicare and Medicaid clinicians and hospitals to use electronic health records with open APIs certified to the 2015 edition in order to enable patients nationwide to view, download, and transmit their health data. Well, where did this come from? In 2015, the ONC and CMS proposed the potential democratization of electronic health information exchange by requiring the use of patient-facing APIs. So CMS and the ONC proposed that patients have access to their electronic health data stored in EHRs throughout open APIs that would allow patients to view, download, integrate, and share their health data whenever they chose. A family caregiver, an emergency department, a community clinic, a third-party digital health app. CMS and ONC required that these patient-facing APIs take effect on January 1st, 2019. Essentially, this infrastructure, which allows patients and patients' families to be able to view their electronic health record in real time, had to be in place so that this would be open to patients by 2021. Next slide. What's important about this is that not only will this data be available to patients, but as healthcare providers, we are not allowed to block that information. So what is information blocking? It's a practice, except as required by law or covered by an exception, is likely to interfere with the exchange or use of the electronic health information. And if this block is conducted by a healthcare provider, such as pediatric surgeons, and it states that this practice is unreasonable and is likely to interfere with access, exchange, or use of electronic health record. So there are applicable exceptions that a practice won't violate information blocking provisions. So which data is included in information blocking? For the first 24 months, the U.S. Core Data for Interoperability defines the top tier as information that needs to be included in what is released to patients. And this includes any clinic notes, importantly, labs, immunizations, medication records, demographics, problem list, and vital signs, including pediatric vital signs. The exceptions include psychotherapy and information compiled in a reasonable anticipation of or use in a civil, criminal, or administrative action or proceeding. Next slide. The ONC has defined 8 exceptions that involve not fulfilling a request to access, exchange, or use EHI. However, each one of these exceptions are very specific and have rules around it, which I encourage you to look at their website if you have questions regarding the rules around these exceptions. Importantly, for a physician or for a provider, the preventing harm exception, which I will discuss in just a moment, is one that we have to assess in the clinical scenario of whether or not a patient's life could be put at risk or if they could be put in danger of physical harm. Next slide. So, where in the electronic medical record does sensitive information live? Everywhere. We're talking about the immediate release of notes, problem lists, histories, op notes, medication lists, appointments. Everything is going to be readily transparent to the end user, which is the patient and their family. Next slide. Again, in terms of the exceptions, and we want to emphasize these, only in specific circumstances do we believe delaying patients' access to their health information so that providers retain full control over when and how it is communicated could be both necessary and reasonable for purposes of substantially reducing of risk of harm. So again, this is when that risk is a potential physical risk to an individual's life or safety.
So what about adolescent confidentiality? HIPAA, as it applies to minors, generally allows parents to have access to the medical records for children under the age of 18, but there are 3 exceptions. When a minor obtains care at the direction of a court, when a parent agrees that the clinician and a minor may have a confidential relationship, or when a minor has consented for the care and the consent of the parent is not required by state or other applicable law. So that's the tricky one. Adolescent consent really varies from state to state, and they usually apply to sexual and reproductive health services. But on this slide, you can see the types of services that can be involved that include contraception, STIs, prenatal care, adoption, abortion, drug and alcohol abuse, and mental health care. And on the right-hand column, you can see that different states have different laws and some states have no laws at all pertaining to them. So depending on where you practice, you should look into the state-specific laws that may apply to you. So why is adolescent privacy important? Well, it does impact the number of problems that a teen might address with you during an encounter. And foregoing healthcare due to confidentiality concerns can really place certain patients at really high risk. And we also want to avoid potential coercion they may face at home. So this is a delicate balance that we have to weigh. On the one hand, giving patients access to their medical record really allows them to control their health care and convey information on an immediate basis and accurately. But on the other side, there is a need for confidentiality. So on the left-hand side, this is a comment from one parent who says, "Open notes are amazing. I wish all of my son's specialists did this. It has allowed his primary care physician to understand his case better, allowed me to print out neurology reports for his school IEP, and to refer back to our previous care decisions, which change often with a medically complicated child. Honestly, my son's disorder is so rare and complicated, we are often the experts educating other doctors. And so having access to everything makes it far easier for me to provide the full context to each new physician we meet, and there are a lot of them. I really wish that more doctors use these open notes." On the flip side, you see this article from the Wall Street Journal where they discuss private conversations with doctors between teens and doctors may lead to sensitive health issues such as vaping, depression, birth control. And these are issues that the teen may not want shared with their guardian. There are other areas of consideration that make this access to information even more complex. In the case, for example, of maternal records and pediatric charts, sometimes in the for example, chart of a newborn infant, we discuss their prenatal history. Well, this gives the child potential future access to their maternal records, which may include maternal behaviors, maternal ingestions during the prenatal period that the parent may not want their child to have access to in the future. Also, all guardians will have access to the maternal record through the child's chart. So, for example, in the case of potential non-paternity, both guardians would have access to that record. And so these are things that we have to be cognizant of as we document now in the charts of our patients. Also, in the case of child abuse or neglect, the parent or guardian may be a threat to the patient. And so how we document the physical findings as well as our conclusions and our suspicions must be carefully documented or segregated in the chart. There are clearly legal considerations to this. And then even in eating disorder patients, for example, the simple act of documenting the patient's weight in their vital signs may impact that patient's self-image. It may further worsen their eating disorder. A visit, for example, with the nutritionist, where the nutritionist maybe calculates out the caloric intake, that may also impact the teen as they access their own medical record. And finally, in the case of transgendered patients, we need to be very cognizant of the pronouns and preferred names that patients may prefer. So your medical record may default in a smart phrase or a dot phrase. They may pull in the legal name that the patient was first registered under, but that may not be their preferred name, and that may not be the name they want to see reflected in their medical record. So this is a very complicated table, but it kind of shows all the various areas where patients and their proxies, their parents, have access to in the medical record. And this is one example of a sample ideal state that, for example, our institution is trying to reach. So on the left column, under proxy account for under 12 years old, you can see that all the information is essentially released to parents for children under the age of 12. And on the far right, you see adult patients, 18 and over, they're able to access all of their records. The complicating and confusing part are those three columns in the middle. So in our institution, we have what's called a teen basic account currently, and that's for 13 to 17-year-olds. And you can see there's some data that are released to the patients and others that are not. And then on the second to the right, you see the teen proxy account. That's what the parents can see. And you can see currently that the teen basic and the teen proxy don't really overlap. The future state is what we want to see in the middle, where the teen enhanced account, the teen has access to everything. Getting to that middle column is what each institution has to work to parse out what notes are sensitive and not, and what can be released and not. Okay, so one way around teen privacy or sharing of sensitive information is the do not share workflow. This is a sample from our institution from Epic. I think this is a very common workflow for those who use Epic as their EMR. But there is a workflow within Epic for a provider to block a note, and this is based on the harm or privacy exception that Tony discussed earlier. So in this case, the provider would deselect the share with patient. You see that's the top right button. And then they would use the do not share dot phrase. And once that dot phrase is pulled up, it gives the provider predetermined exceptions that the provider can select for the basis for why they're not sharing this particular note.
Thank you, Stephanie. At my own institution, this particular smart phrase, when utilized, actually does not get incorporated into the progress note, discharge summary, or whatever note you're working in. It's actually a flag that's placed on top of, if you will, the progress note that you're not sharing, which explains why the note isn't being shared, but won't necessarily be able to be discovered down the road if the medical record gets opened up to the patient or their family, and they won't be able to read the phrase to protect the physical safety of the patient and others. This note will not be shared on the patient's online account, or any other reason why this is not included. Next slide. So there are some exceptions regarding the ability to share the medical record. So there is an infeasibility and content and manner clause that allows for the inability to share a note. So if there is not an effective way for a surgeon or a provider to be able to share an electronic health record or information, then that provider is allowed the exception. The flip side is that if the record content may not be made available in an electronic medium, if there's an alternate way to provide that information, then the provider is obligated to provide the information in an alternative form. Next slide. There is also a HIPAA privacy rule exception. And essentially, if the provider is unable to verify that the person requesting access to the electronic health information is either the patient or someone that has right or access to that information, then the provider does have the right to not share that electronic health information, and it will not be considered information blocking. Next slide. So there were two timelines that the ONC published, and currently we are set to progress with the timeline that's listed here. The regulations went into the Federal Register of May of 2020, and starting on April 5th, 2021, the info blocking provisions begin, which means that if you actively click on your electronic health record not to share the information, it has to be for one of those 8 reasons that were listed earlier in the slides, or you are information blocking. And as you can see there, the rest of the timeline marches out. The remainder of the rollout is scheduled by CMS and the ONC, with the ultimate goal in October of 2022, expanding the info blocking scope to sunset the exceptions that were listed earlier so that all electronic health information can be accessed by patients and their caregivers. Next slide.
So we went over a lot of information today, and we'll try to sum this up in some key takeaways. As of April 5th, 2021, the date is knocking on the door, patients and their proxies must have immediate access, electronic access, i.e. through a portal or an app, to most of their electronic health records. So this includes notes, labs, medications, problem lists, vital signs, etc. In certain states, adolescents may have the right to privacy from their parents for certain medical conditions and treatments. And in order to best serve our teen patients and guardians, we should continue to work to segregate teen-sensitive data so that we can release as much health data as appropriate to both teens and their families. Where it's not possible to segment the teen confidential information, the infeasibility, content and manner exceptions to the information blocking provisions may apply. So, recommendations for providers. Anticipatory guidance will be critical. You might even consider creating some smart phrases within your EHR to assist you. This will prompt you at what things you should and should not write or include in your documentation. You may even consider advising your patients and their proxies not to look at certain notes or test results until they hear from you so that you can walk them through it. This is especially true to, say, pathology and radiology results. You should just develop a procedure to provide anticipatory guidance to families at the time of the procedure. I know for one, our pathologists often like to use a lot of terms, describe a lot of stains, discuss a lot of things that they have chosen to rule out. Parents and patients may not understand the terminology. They may not understand that ruling these out are in the normal course of business for them. And so seeing a lot of terms that were never discussed with them may be very anxiety provoking. So that is where anticipatory guidance will be key. Also learn to write an open note. Open notes are what we call progress notes that are immediately available to patients. So most patients do want to see notes that are as they are currently written, which include specific medical language, because they will share these notes with other medical providers. But we want to consider alternate wording in some situations, things that are often misunderstood, abbreviations or phrases that could be interpreted in a way that you did not mean. Special considerations need to be given to behavioral health notes, adolescent care, and notes that can be involved in legal proceedings as we've discussed earlier. Adolescent notes and results will have the same configuration as for adult notes 18 and over.
One thing to consider, Stephanie, as well, is the pre-charting. So some of these pre-chart notes might be available once you hit pend or share, and skeletonizing an op note or skeletonizing a clinic note might be readily available to a patient's family depending on the function of your EHR. So that's another thing to consider.
That is a really good point.
So,
Our institution won't share it until you hit accept, but I have personally learned that sometimes even though you hit accept, you might want to go back and addend a note later.
yes.
Just be very cognizant of that. I now reread my op notes 2 or 3 times before I hit accept. Other shared documentation recommendations. So write what you discuss and discuss what you will write. So patients generally want considerations discussed. So we often in our notes might write our differential diagnoses, or if it's a medical student note, they might want to share all of their medical knowledge and list 10 different differential diagnoses. That needs to be either tempered, or we need to share that with parents and patients so they understand why this is included in the medical record. So for example, malignancy is possible but unlikely at this point. If you list something like that in your differential diagnosis, make sure that the family realizes that you have considered this and ruled it out and that you've discussed this with them. You also want to document objectively, describe behaviors rather than judgments. So one way you might see something currently phrased in the medical record is this unfortunate poor historian, where the more objective way may be to simply state patient unable to recount a clear history. I know we often have the habit of saying something like this lovely 13-year-old. And while it is very nice to say something like that, if you don't include that next time, the family might wonder why their child is no longer lovely to you. You also want to avoid medical jargon and abbreviations. The patient denies SOB. In medical language, SOB means one thing. In colloquial language, it means other things. So it might be more clear to say something like states no shortness of breath. And you should engage patients and seek feedback. Encourage patients to review your notes. Make it obvious that you're not trying to hide anything. You want to share your notes and you want them to understand what it is that you are saying. One thing that I often encourage my patients to do is to send me notes in our patient portal, which is an app. So one thing you can say at the end of every visit is, review the notes from today. If you have any questions, just send me a note in the app. You can also go to myopennotes.org, which is a great website to give you more tips on how to write clear open notes.
So I'd like to especially acknowledge Rhett Walker from Multicare Health System, who allowed me to adapt some of his slides and explain the Cures Act to me.
And I'd like to thank Rachel Goldstein and Natalie Pagler from Stanford Children's Health, both for their guidance and explaining much of the Cures Act to me in the use of their slides as well. Good luck to everyone.
Good luck. Thank you.